And we are live. Good evening and welcome to our Waltham Public Library program, Race and Childbirth in America. This program is supported by a grant from the Waltham Cultural Council. And my name is Deborah Hoffman and I organize programs and events for the library. And thanks so much for tuning in. Before we start, I want to let you know how the evening will go. Our speaker will do about a 30 to 40-minute presentation, and then she'll field questions. To ask questions via the chat function, use a Google account to sign into YouTube. Feel free to write your questions at any time, and then I'll read them at the end of the presentation. Dr. Wangui Muigai is an assistant professor of African and African American Studies and History at Brandeis University. And we are so honored to have her tonight. Over to you, Dr. Muigai. Thank you.
Great, thank you. Thank you, Deborah, for inviting me. And thank you all for joining through YouTube today. I have to say I've been really impressed by the programming that the Waltham Public Library has been offering. Just a few minutes before Deborah and I were talking, and I lived in Waltham for 2 years, and I would walk over to the library, like for the annual book sales, and it's great to see how the events have, really shifted and taken advantage of the virtual platform, through events like these speaker series. So I'm a historian of medicine, and in the broadest sense, what I study is how people living in the past have understood why they got ill, what made them sick, and how they could get better. And in my research and teaching at Brandeis, it really focuses on these historical experiences, these historical perspectives, and thinking about how they can inform the health issues that we face today. We often think of disease as a biological event, something that goes wrong in our bodies or in our minds that gets diagnosed by a physician and treated with drugs. But being sick is also a deeply social experience. It's one that is shaped by our community, by our access to care, and especially in the US, by one's race. And when confronted with health illnesses or health crises, people turn to a variety of places for help and for comfort. Think about all the places you go, beyond the clinician or beyond the doctor's office when you feel unwell, when you need to be comforted. And so, looking at the history of childbirth, I think is such a rich example of not only taking on big changes in medicine, but also big changes in how we live, in how our societies are organized. And so my goal for this evening is to move through this history by discussing some of the lasting concerns and questions that have shaped women's birthing experiences and how they have impacted Black women in particular. So I'll begin by talking about the risks that women have faced during childbirth and what I call these twin shadows, the shadow of maternity and the shadow of slavery. And from there, I want to look at who has been by the bedside. Who are the people women have called on and trusted to see them through birth? And this means looking at the role of physicians, both Black and white physicians, and also the important role that midwives have played. And from there, I'll take a step back and really put this history of childbirth in the larger context of what is happening and what has happened to Black healthcare, what that has looked like in the US during a period of legalized segregation and afterwards. Why do we continue to see different birth outcomes for Black and white women today? And I'll just say that there's so much more that we can cover, but my aim here is to really set the scene, to give a broad historical context so that I can engage in the questions that you all have. Now, women have long reckoned with the dangers of childbirth through experiences they themselves had or have witnessed among their female friends, among relatives, neighbors. Women have known that the cycles of pregnancies, of miscarriages, births, nursing, that these come with risks. They come with risks of death. They come with risks of injury and harm. And the historian Judith Levitt has described this as the shadow of maternity, a shadow that haunted and really threatened the lives of many women and their children. And for enslaved Black women, they faced additional risks during childbirth as their experiences of being sold, of being separated from family, of being assaulted and raped brought them in close and constant proximity to sickness and loss. And they faced additional obstacles in getting medical care. They had to confront what, I want to call this additional and ever-present shadow of slavery. We can see this clearly when we look at the life story of Harriet Ann Jacobs. Jacobs was born a slave in North Carolina in 1813 and grew up in the hands of an abusive medical doctor. He was her owner. He tormented and assaulted Jacobs for years. And her experience with birth and with motherhood were all deeply shaped by this experience, by this harassment that she suffered as a slave in the hands of her owners. In order to escape and save her children from a similar future, Jacobs ran away. She hid in a tiny crawl space, basically under the roof of her grandmother's house. It was such a narrow space, she wasn't even able to fully stand. And she stayed there for 7 years until it was safe enough for her to escape north to New York and to Boston, where she was eventually reunited with her family. And the reason why we know so many details of her life is because in 1861, Jacobs famously published her story right in Boston and titled it The Incidents in the Life of a Slave Girl. And this is one of the most well-known and informative slave narratives written by a Black woman. And in her memoir, Jacob describes her perilous experience becoming a mother. She was at the age of 16 when she gave birth to a son named Joseph. And she recalled and wrote, "When my babe was born, they said it was premature. It weighed only 4 pounds, but God let it live. I heard the doctor say I could not survive till morning." So neither newborn nor mother were expected to live through the night. Now, at this time in the mid-19th century, many white and Black women died in the process of carrying a pregnancy to term. About 1 in every 30 women could expect to die in childbirth or as a result of a complication in the postpartum period. Complications like puerperal fever, or commonly known as childbed fever, which struck within days of delivery and caused high fevers, sharp pains, and even delirium. And Jacobs had many of these same symptoms, but what distinguished her birthing experience and that of other enslaved women in the time was the painful reality that the children they gave birth to were someone else's property. Now, as she was recovering from her premature birth, Jacobs described that her master, Dr. Flint, continued his visits to look after my health. And he did not fail to remind me that my child was an addition to his stock of slaves. Now, Jacob's owner viewed her newborn son, Joseph, as simply property, as something that added to his wealth. And the doctor was interested in Joseph surviving only because it meant he could eventually sell him and reap those profits, right? Reap those financial rewards. Now, both Joseph and Jacobs would go on to recover. But the fear that she expressed of being so close to death when she was trying to bring forth new life, this gives us a window into just how immediate and how direct these risks of childbirth were for women in the 19th century. Now, Jacobs was owned by a physician, Dr. Norcom, and he ran a pretty big medical practice in North Carolina. He was even known for his charity work. But the way he tormented Jacobs really raises this question of how Black women historically have been treated within the medical profession. Now, enslaved Black women were central to the development of reproductive medicine, especially American gynecology. The physician, Dr. James Marion Sims, he's considered the father of modern gynecology, but his work was only possible because of the bodily and the skilled labor that enslaved women performed as his nurses who assisted him, and also as his experimental subjects that he used to perfect his surgical techniques. Now, Sims's work reflected a broader approach that physicians have taken when it comes to women's reproductive health, especially issues surrounding childbirth, in that doctors are more likely to use instruments, to use equipment like forceps in order to help speed up the birth process. But in doing so, so often the use of these instruments are often, they cause tears. They can lead to injury. They can lead to internal damage in women's organs. And so both this threat of injury and the threat of being harassed, of being treated disrespectfully, gave Black women plenty of reason to avoid, or at least be wary of seeking the care of physicians. Now, with the dismantling of slavery and the rise also of medical schools in the US by the 1860s, the healthcare options started to change for Black women. And I want to flag two physicians who really dedicated their careers to providing compassionate care to Black mothers and their babies. And this is Rebecca Davis Lee Crumpler and Rebecca Cole. And unfortunately, we don't have photos of them. They aren't lionized and sort of held up in the archives like some of these other white male physicians, but we do know a little bit about both of these women. So Rebecca Crumpler was the first Black woman to earn a medical degree in the US when she graduated from New England Female Medical College, which was located in Boston. And she graduated in 1864, and this was a school for women physicians, for training women physicians. And 3 years later, Rebecca Cole followed in her footsteps when she graduated from Women's Medical College of Pennsylvania. Now, both of these Black women physicians faced significant barriers to pursuing their careers in medicine. And just to give you a sense of how singular they were, when they graduated from medical school in the mid-1860s, there were about 55,000 physicians practicing in the country. So we have about 55,000 doctors. And of that group, only 270 of them were white women physicians. And only 180 of this 55,000 were Black male physicians. And only 2 of them were Black women physicians. So only Rebecca Crumpler and Rebecca Cole amidst, almost 55,000 physicians. And these women dedicated their careers to treating Black mothers and children. They helped train Black midwives. They traveled around the country providing care to the poor, including to newly freed Blacks following the Civil War. So Rebecca Crumpler was working in the contraband camps down in Virginia, right in the aftermath of the war. And in 1883, she published an infant care guide that she filled with lots of practical advice intended for mothers, intended for working mothers. This was the first book published by a Black woman physician, and it focused on infant care. It focused on dispensing information and advice for Black women so that they could survive and enjoy their birthing experiences and their journey into motherhood. The work that both Dr. Crumpler and Dr. Cole undertook in this late 19th century to help Black mothers and newborns, this paved the way for later generations of Black health practitioners who would go on to work and advocate to make childbirth safer in their communities. But if we really want to understand how the majority of Black women experienced birth, then the person that we need to look to is not the physician, but the midwife. Because Black women were more likely to rely on each other, especially those skilled in midwifery when they were pregnant and nursing. Now, in the early 20th century, most Blacks in the US were born in the South. And we see this on this map on your right, where these darker shaded areas indicate where the highest number of Black births occurred. And at this time, Black midwives attended more than half of all Black births across the country. So that small bar chart on your left shows this. We see that in the 1930s, for example, 50% of white women were giving birth in hospitals under the care of a physician. But for Black women, 50% of them were giving birth at home and with a midwife in attendance. In parts of the Deep South, like in Mississippi, that number rose. Black midwives delivered over 80% of Black babies well into the 1940s. Black midwives had long stood as pillars in their communities. They provided vital health care from slavery through to the 20th century. This practice, midwifery, had roots in traditional African practices as a form of knowledge, a form of learned skill that was passed down across generations. And midwives spent years apprenticing under each other, apprenticing under more experienced midwives. And through their work, agriculturally, through their work enslaved on plantations in domestic spaces, they developed their herbal knowledge. They grew to understand the healing properties of different plants. And many saw themselves also as spiritually guided, as called by God to do this work. And this is reflected in the fact that Black midwives had a holistic approach. They attended not just to the physical processes of pregnancy and labor, but also broader aspects of care, including managing women's pains, managing their anxieties during childbirth. So their work, required a range of nursing skills, pain management skills, even housekeeping skills, in addition to the long time commitments. Whereas doctors typically arrived once the labor pains had begun, and they typically stayed just long enough to cut the umbilical cord and get out, midwives got involved much earlier in the process. Even before we start to see things like prenatal care, you have midwives helping mothers in the late stages of pregnancy, checking on mothers and newborns weeks after they gave birth to ensure that they're recovering well. Now, looking back on her work as a midwife in Virginia, Claudine Curley Smith, who, she described her process, how she would attend to mothers after they gave birth. She would visit for days, a couple days after the delivery, just to check on how the mother was progressing, just to check that the newborn's navel cord was healing properly. And if she saw any signs that it just wasn't going right, then she'd recommend that they go and see a doctor or they seek additional help. And for her, paying attention to the way the mother was healing and also the way the newborn infant was healing with this umbilical cord, with its body, keeping its body cleaned. These were the natural signs that she relied on to give her a sense that she'd completed her work, right? Being attentive to the issues that could arise in the postpartum period. But although midwives were well respected within their communities, beginning in the early 20th century, physicians became increasingly critical of their work. And doctors and nurses frequently described midwives as a problem. They claimed that midwives were ignorant because they didn't have formal school training. They didn't go to receive professional degrees like in nursing or in medicine. And physicians claimed that, even though it wasn't quite a disease, pregnancy was a condition with specific symptoms and specific signs. And these required professional care that midwives couldn't adequately manage. And they argued that midwives were nothing more than old-fashioned folk healers because they relied on botanical remedies like teas and herbal ointments and salves. And some doctors even went so far as to say that midwives were nothing more than just undercover abortionists. They thought that when women were calling on midwives, all they really were trying to do was actually get rid of the pregnancy as opposed to carry it to term. And crucially, doctors blamed midwives for maternal and infant deaths, especially among Black women, even though several studies showed that women fared better and comparably when delivered by a midwife rather than a doctor. Now, this early 20th century period, when there's a lot of criticism and vocal raising about the midwives as a problem, this is also when we're seeing a lot of just general reform interest. Social reformers who today we would probably recognize and call activists, really pushing the government to do more to protect mothers, babies, and children. So there's a lot of movement in child welfare. We see the outlawing of having child workers, for example, moves for children's education, really calls to develop the public health infrastructure in order to save and protect young children from dying from preventable diseases. And facing this pressure, especially from midwives, especially from physicians and medical groups, government health officials started instituting new regulations targeting midwives that they needed to comply with in order to be able to continue attending births. And these were framed under the guise of protecting mothers and newborns and trying to bring down those mortality rates. But officials very much had in mind the goal of eliminating midwives altogether. And they did that by making it harder and harder for them to practice, by giving tighter and tighter restrictions and regulations on the kind of work they can do. So, to begin with, they required that midwives had to attend classes in order to get a license to practice. They never needed a license before to practice, but now they need to meet a series of trainings and classes in order to be licensed to attend a birth. And in these classes, midwives learned sanitary techniques. They learned about sterilizing supplies they used, how to properly cut the umbilical cord in order to prevent any infection. Now, this photo of a midwife cohort, a class that was trained in North Carolina in 1925, this alerts us to some of the regulations that were being imposed on their practice. So in the front row, we have all these midwives holding signs indicating the things that they must do in order to be licensed to practice. Things like call on a doctor if any complications arose during delivery. They must have a license, right? They must have this certificate with them. And we also see an emphasis on hygiene, reiterated in the sign that the new midwife must be clean. Now, many of the lessons that midwives learned in these classes and in these trainings, they weren't typical in the sense that they relied on textbooks or lectures. Instead of those, more traditional modes of education, midwives learned by practicing, by role-playing, by using dolls and singing songs and playing skits. And this is sort of how these lessons were communicated. And to give us a better sense of just what it was like for these generations of Black midwives who were going through this state process of regulation and education, I want to play a clip from a midwife class in the 1930s to give us a sense of what that sounded like. If I can get the clip. Here we go. So in my research over the past 7 or 8 years or so, I've been really looking into the lives and the health experiences of Black mothers and infants. And this was a song that I just kept encountering as I was moving through archives, especially archives in the South, where the majority of Black midwives were practicing and where the majority of them were training in the early to mid 20th century. Now, when you hear this song, underneath it is this familiar nursery rhyme of Mary Had a Little Lamb. And that was typical of a number of the songs that were used in these midwife classes to teach these lessons, right? To pull something that is familiar and memorable and add a new layer of lyrics, of public health messages on top, with the goal that, this is something that we might retain. This is something that midwives will hold on to and remember. And we see here a pretty clear message about what midwives were expected to do, the expectations put on them, their responsibility to have and keep clean clothes, that their bodies should be clean, that all of their equipment should be clean. And the reason that there's such an emphasis on this cleanliness is because this serves as a physical shield. This is what's going to help safeguard mothers and infants from deadly germs. Now, this line, to protect the mother and the baby, emphasizing really that the midwife was the person responsible, but also the person to blame if anything went wrong. And frequently, if any deaths or complications arose during childbirth, health officials were looking to midwives to place that blame, to say this is the reason why maternal and infant death rates continue to be so high. Another place that officials are looking to, or were looking to regulate midwives, to really constrict and restrict the kind of work they could do is around the equipment and the supplies they could use. Right? Like the doctor's stethoscope or even the nurse's white cap, midwives were identified by the black bag that they carried. It contained all the necessary items that they needed to attend a birth, to see a mother through. And it was also really a sign of their readiness. You know, if they were called, all they needed to do was really just grab that bag and then go out and attend to a mother. And in this push to control what midwives could and could not do, health officials began to pay really close attention to what midwives put in those bags. So the supervising nurses, the supervising health officials in these trainings and classes, they would regularly ask midwives to open up their bags and show them everything that it contained. And midwives had long used things like teas made out of herbs and spices because these were known to help relieve labor pains. They were known to help control bleeding. So it would be something that you would brew and offer to a mother while she's in labor to help, ease and smooth out that delivery process. And this was a specific treatment that midwives were using in order to address a discrete set of symptoms. But health officials were really suspicious of all traditional remedies, and they saw things like teas as really secretive attempts to induce a miscarriage or to induce an abortion, as opposed to something that had pain management remedies and benefits to it. So midwives were prohibited from using, what we would now recognize as these more natural remedies, these more natural approaches. They weren't allowed to give mothers anything for their pain. Now, what was the consequence? What are the consequences of this government-sponsored campaign, which really aimed to constrict and push midwives out? As officials intended, the number of midwives practicing began to drop. You see this steadily throughout the state. So, for example, in 1930, there were over 3,000 midwives who had registered to practice in Georgia. That means they had gone through all of these trainings, all these classes, kept up with all the requirements, and there were about 3,000 Black midwives practicing in Georgia. But within 20 years, that number drops down to less than half, only about 1,300 midwives left, as they have to continually renew their licenses, keep up with the inspections, and the real restrictions on what they were allowed and not allowed to do. Now, Black women were not silent. Even when faced with threats of having their licenses revoked or even being fined for practicing without a license, they spoke out. In 1946, one Georgia midwife wrote to the public health nurse who supervised her, and this nurse had taken away her license to practice. And in this letter, the midwife advocated not only for herself, but she spoke out against the lack of options available, making it clear that there was no one left in her county who was willing to take care of expectant Black mothers. She wrote, "I want my job back." And she includes this drawing of herself and a summary of the techniques she had learned from her midwife trainings, right? So here she's explaining not only did she retain the lessons that came in those midwife classes, but she was the one who was willing to support Black women, pregnant and expectant Black mothers who needed her care, who needed someone who was willing to care for them. Because the reality was that doctors were rare sights in rural Black communities. They were more expensive. They were often unwilling to travel to attend births in rural areas. And they were unwilling to go to families who they assumed would not be able to pay them. Now, the midwife Oni Lee Logan, who practiced in Alabama from the 1930s to the 1980s, she had this to say when she recalled what the available resources were like for much of the time that she was practicing. In that time, there was no hospital that they could go to have no baby. They didn't have clinics. They didn't have doctors. A doctor every now and then. When you call on one, even if you call on one today, he might come tomorrow. He might come tomorrow. It was the midwife or nothing. So one consequence of this government-sponsored effort to eliminate midwives is that it endangered Black women's health and their birth experiences. It left them with fewer options of people who were trained and willing to care for them, fewer providers in their communities, and they were pushed to give birth in ways that were both unfamiliar and unwelcoming. Oni B. Logan practiced during this Jim Crow era of legal racial segregation, a period that stretched from the 1870s and lasted through to the 1950s, in which Black Americans were politically, socially, and medically treated as second-class citizens. Through the suppression of political rights and laws mandating racial segregation, including in spaces like schools, restrooms, public transportation, this impacted all aspects of life, and medicine was not immune to this. Although it's less talked about, American healthcare was racially segregated. Racial discrimination in education made it very hard for Blacks to train and pursue careers in medicine. There were few hospital beds for Blacks, as many hospitals refused to admit Black patients. They refused to allow Black doctors and nurses to practice in their wards. And if patients were accepted, they were put in colored or Black-only wards. So that image on our right of the colored obstetrical ward, this is where Black mothers were in a larger hospital. And healthcare clinics separated Black and white patients and putting them into different waiting rooms, into different restrooms. Even the American Red Cross segregated the blood donations it received by the race of its donors. So if we look across multiple levels of American healthcare, we see these policies of racial segregation being strictly enforced. Whether the nearest hospital was a block away or hundreds of miles away, through to the 1960s, Black patients who showed up in need of care were routinely turned away and routinely experienced humiliation of being treated as second-class patients, of receiving substandard care, including the care they needed during childbirth. This is what healthcare looked like during this period. Now, by the 1960s, the federal government assumes a much larger role in healthcare, through the creation of new programs like Medicaid, through the desegregation of public hospitals. And these measures definitely work to increase Black families' access to prenatal services, to medical care. We see more Black mothers giving birth in hospitals. So by 1964, 85% of Black mothers are giving birth in hospitals, compared to just a few generations before, where over half of all Black women were giving birth at home and in attendance and company of a midwife. But equal access did not mean equal care. It does not mean equal care. The inability for Black women to experience the same healthy birth outcomes as other racial and ethnic groups has not gone away. Even decades after our healthcare system has been restructured, has been desegregated, we encounter many of these reports in major newspapers. So recent coverage in the Atlantic and in the New York Times and other news outlets, they're drawing attention to the threats of survival that Black mothers and infants continue to face. The most recent evidence comes from a study that was published just last month in September, in which a team of researchers looked at nearly 2 million births that had occurred in Florida between 1992 and 2015. And in their review, they found that Black newborns were up to 50% more likely to survive birth when they were delivered by a Black physician than delivered by a white physician. And this brings us right back to these key questions and concerns I raised at the beginning, the issues of, where and what is a safe environment for women to give birth? Is it the hospital? Is it the home? How do we take into account not only survival, but also concerns about comfort, about women's dignity? Also thinking about who women should trust to help them through birth. And finally, what has healthcare looked like for Blacks in the US? What does it look like today? What is the role of government, but also individuals in managing and responding to these risks of childbirth? And so, although the story I've told is really one of the past, many of these themes and concerns continue to be sources of debate and concern about how to better ensure the survival of all mothers and newborns. And the birth justice and reproductive justice movements are very much informed by this history, right? The term reproductive justice coming out of the work of women of color activists, Loretta Ross and others in the 1990s. And they were responding to this long history of unequal, of segregated treatment, of the mismanagement of women's reproductive health. And the principles that they developed aim to protect mothers and families from death, from harm, from oppression. These principles of the right to be able to not have a child if a mother chooses, or a woman or a family member chooses to, as well as the right to have a child, and the right to parent children in safe and healthy environments. So the rights that reproductive justice activists are fighting about are not just about choice, or not just about access to competent care, but about the broader structural factors, things like stable housing, food security, protection from environmental toxins, being able to maintain healthy relationships, all of these factors that enable us to make informed decisions about whether and when to start a family if one chooses to do so. So, if this is a topic that you'd like to learn more about, I just wanted to highlight a few other sources that you can look into to really get both, more historical perspectives and scholarly analysis on the issues of Black women's health care, Black women's health activism. The first two that I've included, Listen to Me Good, and this wonderful film, All My Babies, give us a bit more of Black women's own voices and experiences and accounts. And looking at midwife memoirs, there's such a rich collection of Black midwives who shared their stories, their life stories, and their stories practicing. In addition to this 1952 film, All My Babies, that stars an actual midwife, Mary Coley, who practiced in Georgia, and gives us a sense not only of the work she did, but how she assisted mothers during this period of legal segregation, how she worked with nurses and doctors to advocate on behalf of the Black poor women that she served. And it's a really beautiful film. I also have these two other works by Dorothy Roberts and Deirdre Cooper Owens that discuss the challenges and the oppressions that Black women have encountered and continue to, especially around childbirth, when their pain isn't taken seriously, when their right to have children and on what terms are being overridden by government and by the court. So there's a lot that both of these scholars are really putting us to think about. I'll end there just so that we have more time for the discussions, but thanks so much for listening, and I'm really looking forward to your thoughts and to your questions.
Thank you so much. That was a fascinating historical perspective. It really gave me a lot of thought. We do have some questions for you. One is, can you talk a little bit about Maud Cullen? I think that was her last name. She was in one of the photos that I had seen. Can you just talk a little bit about her?
Sure. So Maud Cullen was a Black nurse midwife who was practicing in South Carolina in the 1950s. And she was, let me go back to sharing my screen. Her work was chronicled in Life magazine in the early 1950s. And so readers at that time, would open Life and they just saw these beautiful Black and white accounts and photos of her work, really highlighting the tough and rural conditions in which she was not only, assisting mothers in birth, but also tending to chronic illnesses and public health issues in these very rural communities that she was working and attending to. And her story was, documented both through really arresting photos and a text, and served as one of the inspirations for putting this film, All My Babies, together. This was a period right out of the Second World War, where those kinds of images that were just so realistic and really transported readers and viewers into other parts of the world were really arresting. The thing that's interesting about the film All My Babies, as opposed to Maud Cullen's description in her piece in Life magazine, is All My Babies was a film that was used to train Black midwives. It was another project that health officials working with a number of different groups, put together because they thought that this film would be a really great way to communicate a number of lessons to midwives, not only in the US, but maybe even around the world. And so you have a group of practicing Black Georgia midwives who are at the center of this story, really kind of making vividly clear just what healthcare looked like when it was, quote, separate but equal. When Black mothers were, largely denied the ability to be admitted into hospitals, and where Black midwives had to very carefully and strategically walk a line where they were needed and they were very critical, and health officials recognized that, but at the same time, there are limits in terms of what they can do. So both Mary Coley in this film and Maud Kalin in Life magazine are, at the forefront of this generation of Black midwives and nurse midwives who are very cognizant of their responsibility and taking advantage of abilities like a film or a Life magazine profile to really raise awareness about Black health conditions in the 1950s.
Great. My understanding is that low birth weight is the #1 cause of infant mortality among Black babies, and that low birth weight has been linked to maternal stress. Can you talk a little bit about the role that racism plays in maternal stress?
Sure, definitely. So, first of all, I think that your question is a great one because it's important for us to think about the fact that the leading causes of maternal and infant death have changed over time. And in the mid-19th century and the early 20th century, there was a lot of concern around infectious diseases, whether it was childbed fever or certain forms of tetanus, that these were major causes of death among infants and young children and among pregnant and laboring women. And over time, those causes have changed in terms of, now we think we're paying attention to low birth weight, we're paying attention to sudden infant death syndrome, we're thinking about birth defects. And so even as childbirth itself, of course, has been this constant, the risks and the threats have changed over time. When it comes to looking at low birth weight and understanding or trying to understand the connections related to race and racism, there is a way of thinking about it that the scholar Arlene Geronimus has described as weathering, which she puts forward as a weathering hypothesis, where she frames that really there's something about being Black in America, about being a Black woman and managing on a day-to-day sort of really practical level, just the stresses that come with that, the stresses that come with navigating racism in all the ways in which it manifests, where you essentially sort of have to fight day-to-day this battle of being discriminated against. And, whether those are stresses or the kind of toll that takes internally is that we can think of it essentially like a house weathering a storm, sort of being battered all the time, sort of across all sides as the storm is moving through. And that really wears down on the body. And that is, one of the ways in which, researchers have tried to understand how does racism, internalized stress, affect birth outcomes in terms of seeing low birth weight, in terms of seeing higher rates of prematurity, that this sense that we can measure stress, we can measure something called the allostatic load within Black women, and that is shown to have a connection in terms of what the outcomes are. But there also is a way in which interactions, individual interpersonal interactions within healthcare systems, Black women being not recognized in terms of their pain, not having their complications being taken seriously or ignored or kind of pushed aside, that can very quickly escalate what might be something that's quite preventable into a life-changing complication. So, you know, it's kind of taking sort of all of these multiple dimensions and ways in which racism manifests and could have an effect and an impact on a moment when a woman is delivering and is laboring.
Okay. I have a question. Your thoughts on implicit bias training for doctors, nurses, medical students as one tool to reverse the high mortality rates for Black mothers? I guess, what are your thoughts on that? This person is wondering how doctors would react to such a requirement.
I think that the way the question is framed is really important, because I think it is one tool, and I think it's definitely you know, isn't the one size fits all approach. I think, you know, with the threats and deaths surrounding childbirth, and really why the US, compared to so many other industrialized countries, has such high maternal and infant mortality rates, despite us as a country spending the most, you know, per person per capita on healthcare, really belies the fact that this is an incredibly complex issue, and one that cannot be addressed with a single, you know, sort of magic bullet solution. And definitely when it comes to training physicians, training medical students, training any kind of healthcare practitioner, you know, to really pay attention to what their patients and those that they come into contact with for providing care are saying, to address implicit biases or assumptions, language barriers. I think that is important, but it isn't only on the level of the individual. And, you know, part of what I tried to do with the initial framing was just draw out the larger structures that were in play, where, you know, a physician or a nurse or a midwife could mean well, but what does that look like in the broader context if issues of access, if issues of compassionate care, accessibility, availability are still very largely dictated in terms of who can access them based on their race, gender, or class. And so in that sense, individual trainings, I think, are important and only one part. I would also say that, you know, knowing the history is important. So even, you know, just beyond sort of coming in and doing trainings on implicit biases, I think it's very important for like medical students, for clinicians to understand the ways in which racism and race have been so fundamental to the development of American medicine and healthcare, that this isn't a side issue. This isn't something that we can just sort of cabin off, but it really has structured the way that our system has developed. And it is structured and built, you know, particular medical specialties. And I think bringing that context in is really important, because you realize that, you know, the most vulnerable aren't a specific or, you know, a special or a sidelined population group, but that it's really in centering the most vulnerable. It's in centering women of color, it's in centering Black women, and addressing their care and their concerns and their health needs, that you sort of open up the possibility of a more equitable system, and one in which more people survive. So it's just, I think, another call that definitely more education and training is needed. Implicit bias training, I think, is one part of a larger kind of arsenal of tools that we should be deploying.
Right, right. That makes total sense to me. So I did some reading before tonight and learned about these two different research models, and I'm just going to ask if you're familiar with them, and then if you are, if you could talk about them. One is called the early programming model, and it talks about exposure to risk during sensitive periods, developmental periods in a person's lifetime, and how those can affect health later. And then the cumulative pathway model talks about stress across time and that allostatic load that you talked about, and the fact that the more stress you have over time, the more negative impact on your health. Are those two things things that you're familiar with and that you could talk about, or is that sort of outside your area?
I'm definitely familiar with the second model, right? The cumulative model, and less so with the first, but I think that this, the attention that is now being paid, especially in research areas, for just understanding how does stress affect the body, not only over time, over the life course, also thinking about it intergenerationally, and what are the ways in which we can measure those outcomes is really important. And I, as a historian, when I hear these models and when I think of these, come across these conceptions, I'm thinking, what are the alternate modes of explanation that people have deployed in the past? Because again, as even as the coverage in magazines and news is pointing very due attention to the maternal mortality crisis and the infant mortality crisis, these aren't new crises. These aren't news in the sense that they're just developing. They have been ongoing, and they're really reflective of, as I said, this structure of health and healthcare that we have in the country. But because higher rates, Black communities have experienced higher rates of maternal and infant mortality than whites across the 20th century, that also means that people have come up with a number of theories and models and ways of explaining them. And sometimes it's ones that are rooted in biology, saying that there's something inferior or inherent in the way Black people are that leads to these outcomes. Some models and some explanations focus on behavior. They focus on maybe what the home environment is like, or what parenting environment is like, or even things like what kinds of groups or who are more and more likely to seek prenatal care, who are more and more likely to listen to their physician, to follow their physician's recommendations. All of those are judgments and assessments about behavior and trying to tie that to birth outcomes. And then there's also models that are looking at the larger environment, the social, economic environment in which babies are born, in which people die, and saying, is there something that we should be paying attention to, whether it's the quality of water? And that is something that we can think about, today in a Flint, Michigan era, but also in the early 20th century, when we are starting to see the development of sewage systems. We're starting to see the development of milk pasteurization, this effort that we actually really do need to control and regulate the water and the milk supplies in order to prevent death, in order to prevent the spread of disease. That's more of an environmentally focused model. And so those are the ways in which I tend to engage with all of these, to just kind of sort of track them over time and think about now, we're starting to look much more internally. We're trying to understand, physiological pathways. We're trying to think about, how do we explain what is a larger phenomenon? How does that get rooted in the body? And I think there is something interesting there, but, there are also a number of other ways in which different kinds of researchers and scholars have tried to get at what is still such a pressing and enduring public health issue.
Right. That's a really good perspective. I appreciate that. I think we're set on questions. So I'm going to end the live stream. If you want to stay on for a second, you and I can chat. But thank you all for tuning in. And thank you very much, Dr. Muigai, for your great presentation. Good night, everyone.